So the optic nerve, we know, carries our special sense of vision or sight, and there are a number of things that we do to test optic nerve function. So we test visual acuity, don't we, using the Snellen chart. We test our visual fields by confrontation, and we also do a number of important reflexes that use the optic nerve as the afferent limb, so our pupillary light reflexes and our accommodation reflex. We would also undertake fundoscopy when we're examining the second cranial nerve, but just remember that fundoscopy is not a test of function, but rather it's allowing us to directly visualise part of the optic nerve. So here we're looking onto the back of the left retina, and we can see here is the optic disc, and this represents the macula. And so fundoscopy is allowing us, as I've said, direct visualization of parts of the cranial nerve, and because it doesn't have any photoreceptors in that area, it's also responsible for our blind spot. So the optic disc is effectively made up of those hundreds of thousands of retinal nerve ganglion cells as they're exiting the back of the eye to form the optic nerve proper. We know that on fundoscopy we can look at changes in the area of the optic disc that may indicate that there's some underlying pathology. So for example, optic disc cupping, if you can remember what we see that in, that may be seen in glaucoma. So if there's been high intraocular pressure, so high pressure inside the eyeball, what can happen is we can start to get death of some of those retinal ganglion cell axons, or effectively the axons that are forming the optic nerve, and we start to see increase in the pit, the sort of central depression in the middle of the optic disc starts to get increasingly wider. We can also see problems where the optic disc looks swollen, and maybe the margins of it are becoming a little bit blurred, and that would indicate underlying raised intracranial pressure, of which there are a number of conditions which may cause that. So that's fundoscopy. So thinking about the root of the optic nerve then, as I said, it arises from retinal ganglion cells and the axons, which exit through the back of the retina, and therefore we can have impairment of optic nerve function in any diseases that affect the retina. So if the retina becomes detached, or we have diseases affecting the blood supply to the retinal layers, or the vascular layer just immediately underneath the choroid, then we may start to see disruptions in effectively optic nerve function. So once the optic nerve exits the back of the eyeball, it will need to get out of the orbit through the optic canal. So as it passes through the optic canal, that brings us to sort of the boundary really between the very back of the anterior cranial fossa and really into the sort of middle cranial fossa, where we know that the optic nerve from the right side meets with the optic nerve from the left side at a point known as the optic chiasm. And we know, or you know from your learning in nervous system, that at this point here we get crossing of some of the fibres from the right side with some of the fibres from the left side, and vice versa. Not forgetting that, so from the point of the chiasm onwards, we then refer to it as the optic tract, and there is a communication from the optic tract on both sides to the midbrain, and this is the circuitry that's important in our pupillary light reflexes. So don't forget that there is also communication from the optic tract with the midbrain that helps with the afferent limb of the direct pupillary light reflex. The tracts are then what follow into the forebrain. So just like the optic nerve, the olfactory nerve, the optic nerve is not really a true cranial nerve, but an extension of the central nervous system. So what we're getting into is obviously forebrain, but it goes as far as the occipital lobe, where it's perceived as vision. So the action potentials that come in through olfactory nerve, tract, optic nerve and tract are perceived as vision. But to get to the occipital lobe, which we know is right at the back of the brain, the tracts have to pass through other regions of the brain, and we know that beyond the tracts they're then known as radiations as well. So we know that they have to pass through the parietal lobes and also the temporal lobes before they actually reach the occipital lobe. So there's lots of points there along the pathway of the visual or the visual pathway in which pathology may interfere with it. And you learnt a lot about strokes in the nervous system and how they might interfere with the visual pathway and cause specific patterns of visual field deficit. And that is where I've kind of linked in here with a couple of examples, or a few examples, of visual field deficits. So if you haven't already, pause the video and see if you can work out where the problem might be within the visual pathway and what are descriptors for these types of visual field losses. So this one is monocular visual loss. So that means that we've lost vision in just one eye. And that usually indicates that the problem is either, in fact, affecting a large proportion of the retina or somewhere along the optic nerve just before it reaches the chiasm. Once we get to the chiasm, we've said that there is a mixing of fibres from the left and the right eye, and therefore pathology affecting the optic chiasm will tend to cause visual field defects affecting both eyes. So our one that we hear quite a lot about, or you have heard a lot about, is bitemporal hemianopia, and a common example of why that might occur is in a pituitary adenoma, because the chiasm is in very close proximity to the pituitary gland there. Our final two, and I haven't put all sort of variations of visual field defects on here, but here we have a homonymous hemianopia, and then we're getting our homonymous quadrantinopias. So obviously we're getting further and further back in terms of the visual pathway here, so affecting parts of the optic radiations, and here the inferior radiation before it reaches the occipital lobe.